we will go to this pattern and cells. I think you all might have taken a snapshot of this. So canalicular pattern, whenever you see canalicular pattern, there is only one condition, canalicular adenoma. When you see glandular pattern, these are the differential diagnosis. I'm not going to read about individual conditions because we will be seeing the pictures of them. When you see cribriform, very, very important. These are all the DDs. Cystic lesion, differential diagnosis. Mucinous lesions, differential diagnosis. Papillary lesions, differential diagnosis. And diverse pattern, differential diagnosis. Okay. Snap time, screenshot time. So these are all the various patterns and various tumors in the salivary gland. Coming to the cells, there are 5 types of cells. We have a good number of cases for squamous, few in sebaceous, many in oncocytic, many in small blue cells, and some in clear cells. So sorry, not some in clear cells, many in clear cells. But whenever you see clear cells, first think of metastasis. We usually think of RCC, but please remember there is a clear cell melanoma and there is a clear cell follicular carcinoma. Okay, please remember that too. And when it is a primary clear cell carcinoma, see whether they are benign or malignant. When it is benign, think of pleomorphic adenoma, myoepithelioma, and oncocytoma. When it is malignant, whether it is pure clear cells or predominantly clear cells. When it is pure clear cells, is it dimorphic or monomorphic? When it is monomorphic, it is clear cell carcinoma, myoepithelial carcinoma, and sebaceous carcinoma. When it is dimorphic, we already saw it, epithelial myoepithelial carcinoma. When it is predominantly clear cell, it is mucoepidermoid and actinic cell carcinoma. I think it's a snap time, screenshot time, because clear cell carcinoma of salivary gland is one of the university questions. Canalicular adenoma, canalicular is nothing but tubular cells which are communicated. Okay, all tubules communicated and they will form epithelial knots. And S100 and cytokeratin 7 is a very classic marker for canalicular adenoma. When you have glandular cells, first you have to see whether it is neoplasm or hyperplasia. Okay, here I want to bring the concept of hyperplasia, adenoma, carcinoma. When you talk about hyperplasia, any hyperplasia, they don't have capsule and they will be freely talking along with the adjacent parenchyma. That is hyperplasia. But when they have a well-defined capsule, the same thing will become adenoma. And when they are infiltrating the capsule, they will become carcinoma. Okay, so that's the sequence you have to remember: hyperplasia, adenoma, and carcinoma. And this is one of the best example of this hyperplasia. Okay, intercalated duct hyperplasia. This is not under this heading. Intercalated duct hyperplasia or adenoma is one of the component, one of the tumor or lesion where they can form glands. All the malignants, sorry, I should have typed it only secretory carcinoma. So this is a salivary gland. You can see well differentiated. You can see glands as well as a lot of adipose tissue. So this is adenoma. Okay, see the difference between hyperplasia and adenoma. Lot of fat component. So this will be adenoma with a stromal component, which is more lipoma. Okay, and wherever possible, you just mention probably fat is 60% and the epithelial component is 40%. Next, acinar cell carcinoma. Acinar cell carcinoma can have various patterns, but here you can see nice acinar cells. And one of the clue for acinar cells, there will be a lot of lymphoid infiltrate. Okay, and this is also known as tumor-associated lymphoid proliferation, TALP. Okay, and remember that advanced histology where the acinar part of the acinar intercalated ducts are positive for SOX10 nuclear positivity, and DOG1 is also positive. So remember the tumor associated lymphoid proliferation. And I have not checked the literature, but I want all of you to check now. Okay, right now when I'm presenting, whether we can use PD1 and PDL1 in this. And that's the concept you have to remember. Whenever you see many lymphocytes in a tumor, think of PD1 and PDL1. And think of microsatellite instability also. Okay, so if you take back medullary carcinoma of the colon or tumors of the colon, that microsatellite instability, they will have a lot of lymphocytes and they will respond to PD1 anti-PDL1 treatment. Okay, one of you please check and tell me in the next break. So they can have solid pattern, microcystic, and follicular pattern, and the cell types may be vacuolated clear cell, oncocytic, or hobnail cells. And when one very good news for Acinar cell carcinoma, we now have a molecular marker that is a surrogate ISC marker called as NR4A3. Okay, and there is another very big person, Dr. Jason in soft tissue tumor. He tells a clue how to remember these new markers. Okay, keep the new marker NR4A3 as your passcode in your cell phone for a week. Okay, so you please tell this week is for Acinar cell carcinoma. So the passcode is NR4A3. And if you keep on using that for 1 week, you will be comfortable with the NR4A3. Okay, next week you go for another condition, but keep writing these things in a notebook. Otherwise, you don't forget the password and then message me, sir, because of your idiotic idea, I'm not able to open the phone. I'm not responsible. Okay, and I want to give a disclaimer. I am responsible for what I am saying. I am not responsible for what you are understanding. My saying may be different from your understanding. For your understanding, you are responsible. Please remember that. And many of the new markers, they are all nuclear markers. Okay, NR4A3. These are all transcription markers. So they are predominantly nuclear markers. Acinar cell carcinoma, NR4A3. Secretory carcinoma, again, I have to change it. It is not mammary analog. It is secretory carcinoma. I will make a note of it to change it. Mammary analog secretory carcinoma. 2 times I have to change. So this will have a lot of eosinophilic secretions, and the cells will be more foamy. And we have a very characteristic translocation. Okay, 1215. ETV6 NTRK3. Don't try to memorize these things. It is not humanly possible. Okay, just remember number 1, they have a specific translocation and they have a marker for that, which is nothing but PanTrack. Before that marker, this is mammary analog, so mammoglobin and even GATA3 will be positive, P63 here and there. But PanTrack is a very good marker. Remember, somebody is talking about panel of markers. So you have to take what is the differential diagnosis. For example, if it is Acinar cell carcinoma or secretory carcinoma, I will do only 2 markers. For Acinar cell carcinoma, I do NR4A3, and for secretory carcinoma, I do PanTrack. Okay, so PanTrack is nice nuclear marker for secretory carcinoma. And when this gland formation is not belonging to any other, or whenever there is a Signet cell carcinoma, or whenever there is a mucinous carcinoma, they are classified under adenocarcinoma NOS. So that's about glandular pattern. So this is the nuclear marker. You can see the cribriform pattern. Okay, and MOIB is the translocation specific for adenoid cystic carcinoma. That is very, very helpful. MOIB. It's a translocation 6-9. Fusion of MOIB and FIB. Well, these are all the things I don't want to memorize. I want you to memorize MOIB or remember MOIB. Okay. So this is the cribriform pattern. Okay. Here I took it from one of the articles where they showed 4 tumors with the cribriform pattern, and they luckily labeled it. A is polymorphic adenoma or pleomorphic adenoma. B is canalicular adenoma. C is again another pleomorphic adenoma, and D is adenoid cystic carcinoma. Okay, so for example, for I think this has to be polymorphic adenocarcinoma. Okay, PAC, it is S100 positive. Just now I told you S100 I won't do it, but for polymorphic adenocarcinoma, S100 is very classic. I show you the picture. For canalicular adenoma, location usually in the upper lip. For pleomorphic adenoma, I'll do PLGA1. Okay, pleomorphic adenoma gene 1, PLAG1. Okay, and adenoid cystic carcinoma, MOIB. So basal cell adenoma and adenoid cystic carcinoma can look alike. Ki67 is very, very useful along with the MOIB. Ki67, I think they use cutoff is 20%. If it is less than they give a wide cutoff 5 to 20%. Less than 5, basal cell adenoma, more than 20, adenoid cystic carcinoma. Okay, and another way to remember nicely between the cribriform pattern, you see where is the mesenchymal component or stromal component. Okay, if it is around the tumor cells are more, stromal cell element is less. Think of basal cell adenoma. Okay, if it is individual cells surrounded by stroma, it is more pleomorphic adenoma. If the stroma is surrounded by epithelial cells, it is adenoid cystic carcinoma. Another selfie time. I love this cartoon. It tells a lot of things. Salivary duct carcinoma, when you see comedodcis in salivary gland, it's a salivary duct carcinoma. And when you go to high power, in between these comedocarcinomas, you can see infiltrating ductal carcinoma breast in the salivary gland. And many times they will show apocrine changes. Okay, so this is nothing but ductal and apocrine carcinoma of the breast happening in the salivary gland. Okay, you will be thinking of comedodcis. So salivary gland carcinoma, we have beautiful marker, androgen receptor and HER2/neu. Okay, very, very important. Cribriform carcinoma of minor salivary gland. Previously, it is called as CAT, cribriform carcinoma of the tongue. Now it is known as cribriform carcinoma of minor salivary gland. Even though we call it cribriform, it will more look like glomeruloid to me. And when you see the high power, you see the papillary carcinoma thyroid. Okay, all overlapping nuclear enlargement, clearing, growing. And when you see it in salivary gland with this glomeruloid or irregular cribriform pattern, think of cribriform carcinoma of the minor salivary gland. And we don't have any specific marker, but SMA may be helpful. Most of the cells will be positive for SMA, but anatomic location and HNE, you can make the diagnosis of cribriform carcinoma of the minor salivary gland. Now we are going to cystic lesions, sclerosing polycystic adenosis, which is nothing but fibrocystic changes, intraductal carcinoma, cystadenoma, and cystadenocarcinoma. Now cystadenocarcinoma moved into adenocarcinoma NOS. But please believe me, this is taken from the internet from a salivary gland lesion. Okay, and this is nice apocrine changes. And whenever there are small glands, you are wondering whether it is carcinoma, just do P63 to highlight the myoepithelial cells. Okay, they will be nicely positive. So this is fibrocystic disease of salivary gland, but for exam purpose, it is sclerosing polycystic adenosis. This is intraductal carcinoma, where you see the cystic lesion with epithelial proliferation lining the cyst, and you can see the myoepithelial cells very nicely in the periphery. And this epithelial proliferation may show low-grade features, intermediate grade, or high grade, like DCIS in the breast. But whenever I have 3-tier system, I don't like it. I want to have only 2-tier system, low grade and high grade, no intermediate. I put all my intermediate into either high grade or low grade, depending upon the features. And the whole world is following that. Whenever there are 2-tier system, it's more practicable. Whenever there is a 3-tier system, it is not practicable. So P63, when you do the nuclear marker, you can very nicely see. That's why previously this is called as low-grade cribriform carcinoma, but now it is renamed as intraductal carcinoma because they are arising within the duct. And this is the best example of intraductal carcinoma, high grade. And whenever you see intraductal carcinoma, you go for multiple depots. Here it looks like low grade, and here it looks like high grade, but here it is having carcinoma. Okay, so this is more like carcinoma arising in a background of intraductal carcinoma. Cystadenoma, like in ovary, you see only the cyst. It is more like serous cystadenoma. And when you see multiple depots and you all embed, and whenever there is solid areas, you embed it and you may see invasive carcinoma, then it will become cystadenocarcinoma, which falls under adenocarcinoma NOS. As I told you, mucinous carcinoma and signet cell carcinoma are clubbed into adenocarcinoma NOS. So the only left alone component in mucinous tumor in the epithelial lesions of salivary gland is mucoepidermoid carcinoma. And this is the best example of mucinous carcinoma. When the mucin is especially extracellular, it is mucinous. When it is intracellular, it is signet cell. CK7 will be positive in salivary gland lesions. And mucoepidermoid carcinoma, it is, it is mucoepidermoid. And so you see 3 types of cells: mucous cells, squamous cells, and hybrid cells. Okay, that has both the features of mucinous and the squamous cells. So depending upon the microscopic picture, it is divided into low grade, intermediate grade, and high grade. and I usually put intermediate grade in high grade. We follow the AFIP system that I will be showing you in the slide seminar. And mucoepidermoid carcinoma can do a lot of mimicking. Okay, oncocytic clear cell. You cannot believe this is mucoepidermoid carcinoma clear cell type. This is mucoepidermoid carcinoma oncocytic type. And sclerosing, I will show you in the squamous differentiation. This is mucoepidermoid carcinoma. Mucoepidermoid carcinoma, mainly these are all myoepithelial cells, so they will be P63 positive. But luckily, we have a translocation marker, MAML2. Unfortunately, it is not widely used in IHC, but FISH diagnosis is very, very important. Whenever you think of mucoepidermoid carcinoma or in the differential diagnosis, you send it for FISH for translocation 1190. So now we are coming to papillary. Previously, there are 3 terminologies. Now everything comes under ductal papilloma. Previously, this is called intraductal papilloma, which is nothing but adenoma in the papillary adenoma in the nipple, or papilloma in the nipple. And there is another terminology which is called cyalladenoma papilliferum, where there is a glandular proliferation with extensive squamoid proliferation over that. Okay, this is where the major salivary gland opens into the skin, that shows irregular acanthosis and pseudocarcinomatous hyperplasia. And when you do marker for CK7, this glandular epithelium and ductal epithelium will be positive, whereas the skin epithelium, the squamous epithelium, is negative for CK7. So this is called as cyalladenoma papilliferum. Now that comes under intraductal papilloma. And there's another variant called the inverted intraductal papilloma that looks like more like a urothelial papilloma within the salivary duct. I always remember whenever I see something, I try to correlate. Do we see anything else like this in any other organ? And if I showed you only this picture, you might have called it as inverted papilloma or papilloma of the bladder. Okay, if that happens in salivary gland, it's intraductal papilloma. Previous type was inverted type. Lastly, diverse pattern. We have only one tumor, which is now called as polymorphic adenocarcinoma. Previously, it is called as polymorphic low-grade adenocarcinoma. Now they removed the low-grade, but they grade it polymorphic adenocarcinoma, low-grade and high-grade. 3 things are very important: border irregularity, architectural diversity, and cytological uniformity. Okay, so you can see the infiltrative borders. And diversity, it can have a glandular tubular pattern, trabecular pattern, papillary pattern, cribriform pattern. So diversity is there. And this is another thing, I got it from Dr. Thompson's thing. Remember, his first name is Lester. And you see in 2016, there is a storm named as Lester, okay, Hurricane Lester. Okay, it has like a targetoid picture. He showed it in this and then immediately showed this. Okay, the polymorphic adenocarcinoma will have this targetoid pattern like in lobular carcinoma of the breast. Okay, so you can compare the storm Hurricane Lester. Okay, and this one is strongly positive for S100. See, that's why I tell always, don't tell always and don't tell never. Okay, S100 protein is very, very useful in polymorphic adenocarcinoma to highlight the thing. And when you see the targetoid pattern, in the breast, they are around ducts, whereas here they are around the peripheral nerves. Okay. In addition to adenoid cystic carcinoma, polymorphic carcinoma is a very well-known entity that goes around the nerve bundles. Okay. Remember S100 targetoid pattern. Hurricane Lester. So now we are going to 5 types of cells. Squamous cell lesions are keratocystoma, squamous cell carcinoma, and sclerosing mucoepidermoid carcinoma with eosinophilia. So it is a big cyst full of keratin lined by atrophic squamous epithelium. And whenever you see keratin, there can be foreign body giant cell reaction. So it is keratocystoma. And this is squamous cell carcinoma. Even grossly, you can see the extensive gray white or pearly white appearance, and this is the major duct, and squamous cell carcinoma arising from the major ducts. So this is another squamoid cells, and you see a lot of sclerosis and a lot of eosinophils. Okay, some mucin secreting cells. So you put everything together: sclerosing mucoepidermoid carcinoma with eosinophilia. Okay, so once you know the diagnosis, then you can see all the features. But you have to see all the features and then come to a diagnosis. Here you can see squamous cells. And the sebaceous, we already covered it. We see the sebaceous lymphadenoma and sebaceous carcinoma, and EMA is the marker. For oncocytic, there are again differential diagnosis: non-rural oncocytic hyperplasia, oncocytoma, and oncocytic carcinoma. Asner cell carcinoma and mucoepidermal carcinoma can show oncocytic features. Okay, in oncocytic hyperplasia, you see multiple nodules. There is no size criteria. Okay, and lot of parenchyma. And when you see microscopically, as I told you, the oncocytic hyperplastic cells are freely talking to the acinar cells and adipocytes, no capsule. Okay, so now no capsule, increased number, hyperplasia. Capsule, here, this is a very nice picture. This is the first time I am seeing that stellate scar. I have seen it in kidney, but I have not seen in salivary gland. So somebody, if they want to do a research, you can do a research. Why oncocytic tumors produce stellate scar? That's I don't know the answer. And when it is infiltrating, it is oncocytic carcinoma. When it is not infiltrating, it is oncocytoma. And when you go to high power, hyperplasia, oncocytic adenoma, oncocytic carcinoma will have the same picture. It is different depending upon what is the border. Coming to clear cells, as I told you, metastatic and primary. Primary is benign and malignant. Malignant is pure clear cell and predominant clear cells. Okay. One very good thing in clear cell carcinoma of the primary clear cell carcinoma of the salivary gland, we have a characteristic translocation, EWS or ATF1 gene fusion, but there is no IHC available in that. And most of the time, the clear cell carcinoma will have hyalinizing stroma on the background. So that's why it is sometimes called as hyalinizing clear cell carcinoma. Okay. And you can see the clear cells, and these are all myoepithelial cells. That's why they are nicely positive for P63. Lastly, small blue cells, cyeloblastoma, small cell carcinoma, basal cell adenoma carcinoma, adenoid cystic carcinoma. This is the most difficult area in FNAC. But small cell carcinoma, you see a lot of apoptotic bodies and crush artifact. Cyeloblastoma happens in kids. And adenoid cystic carcinoma, rapid growth, pain. As madam mentioned, nerve involvement, pain will be there. Basal cell adenoma carcinoma, long duration, slow growth. These are all theoretically very easy to say, but practically it's very difficult. So this is cyeloblastoma, and the lobularity is maintained. Okay, this is other name is salivary analog tumor. They look like salivary gland, but they are more primitive. Probably when they look into embryology of salivary gland at the 20 weeks, 18 weeks may look like this. That's why it is cyeloblastoma. And again, S100 is positive. In addition to polymorphic adenocarcinoma, cyeloblastoma is condition where S100 is more positive. But again, age and pattern, you can diagnose. So this is a small cell carcinoma. It looks like lymphocytes, but when you go to high power, punctate necrosis, and you can see a lot of small blue cells and the chromogranin nicely positive. The new marker is INSM1, insulinoma associated protein. So any neuroendocrine marker positivity, think of small cell carcinoma. So basal cell adenoma, again, there can be a lot of patterns: solid, tubular, trabecular, membranous. And this membranous is very, very important because it is the closest mimicker for our adenoid cystic carcinoma. Okay. So, and this is the trabecular pattern, and this is cystic degeneration happening in the basal cell carcinoma. But when you see carefully, basal cell carcinoma will have the peripheral palisading. Okay. Peripheral palisading even in a cribriform pattern, and they will show that cleft artifact. Those two are very important to remember. And luckily now beta catenin is positive in basal cell adenoma. Okay, and the beta catenin associated proteins are also, I think, LEF, that also positive